Okay, well, for the sake of everyone's time, we'll go ahead and get started and begin going through the slides. So my name is Jackie Rao. I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. We'll go ahead and get started just by like a brief overview of the CQI program in general and what you are a part of as having signed up for MCT2D. So essentially, we'll start with what is a collaborative quality initiative. So MCT2D is one of multiple programs that is funded by Blue Cross Blue Shield of Michigan. That's a statewide quality improvement initiative. What makes these unique is even though they're funded by Blue Cross Blue Shield and Blue Care Network, they're developed and executed by physicians in Michigan. So we have our physician program directors who set the quality improvement agenda and lead the meetings and determine the quality improvement goals in conjunction with the CQI as well. So we have a steering committee that includes primary care physicians, endocrinologists, nephrologists, the physician organization. So it's still very driven by the collaborative and by physicians who are working with the patients and in the hospital systems. CQIs promote partnerships between the physicians, the POs, and hospitals, and also reward on care transformation and collaboration. So the intention of these programs is to help implement evidence-based care and to use the data that we have in our database to drive that change and to help us partner with you to make these types of changes within your practices. So the way that CQIs function, so they are all patient, all payer initiatives. So I'd mentioned on a previous slide that they're funded by Blue Cross Blue Shield, but the idea is to change care overall, regardless of who the payer is. As far as the levers of change for CQI, so we have our data sources and we're working on building out our data dashboards. That's something that we're working on the attribution for endocrinology, and we'll likely have that later in the year so that you can have a dashboard of your patients and look at some of their clinical and claims data there. We also provide incentives for participation. So we'll, in a few slides, look at our current value-based reimbursement measures that you're being held to in this initial year. CQIs typically start very participation focused. So you'll see all of the measures that we have for you in this first year are doing things like attending this meeting, attending our regional meetings, submitting a case summary. As our CQI matures and grows, it will be more related to prescribing the medications for the correct patients and getting patients on CGMs, et cetera. And then change support management, which is what we provide as the coordinating center. So we try to create educational resources, offer trainings, provide the expert sharing of information and knowledge, and create opportunities for you to collaborate with other endocrinology practices, with PCPs, with nephrologists on this patient care. So it's just an overview to give you an idea of some of the other CQI programs. They're generally around different disease states, and most of them are hospital-based. Our program, MCT2D, is the first population health CQI, and it's a little bit different from these other more traditional CQI programs. So we have a much larger patient population in type 2 diabetes than the traditional CQIs that tend to be a little bit smaller. The primary participants in MCT2D are primary care physicians, and then we've also brought in endocrinologists and nephrologists as well. And no other CQIs typically work with PCPs like that. We're working with the physician organizations that you're all part of, the practices, and we'll ultimately want to partner with hospitals as well. And instead of doing the data abstraction that typical CQIs do, we're using data flows that are already in existence through information that's submitted either for claims or for quality data that's submitted to payers as well. So we're not going to be asking you to abstract data from the records or anything to track that performance. And so CQIs, the idea behind them is to drive change in culture and to support those changes that are being made in the practices. So we, like I said, that's driven by the providers and the types of changes that you think need to occur to provide the best care to patients. So we're working with our steering committee. We take feedback from our participating practices on the types of work that you want us to focus on. We use data to improve performance and work to collaborate, and as opposed to being in a more like competitive space. Many CQIs develop like peer and coaching support to help foster learning and to share amongst different practices. And we also are using patient data and feedback, such as patient reported outcome surveys and our patient advisory board, to ensure that we're addressing the topics that are of most importance to patients as well. And so our current quality improvement goals within MCT2D is to increase prescribing of GLP-1s and SGLT2s in accordance with the guidelines, supporting low carbohydrate diets, and expanding the use of continuous glucose monitors. And the way that our program works is we enroll physician organizations in Michigan, and then those POs work to enroll their primary care sites, their nephrology, their endocrinology practices. We do information, or we collect information like the practice change readiness assessments that your sites would fill out. We've trained the POs and practice clinical champions on the quality initiatives, and then we provide support and resources and convene meetings and bring you together to share and learn from each other. Our work is guided by a steering committee of our participating sites and our patient advisory board. And then we'll also provide things like implementation guides and educational materials. We're going to do quarterly reporting on data around prescribing the CGMs and prescribing the medications, and convene regional meetings that likely many of you were at in the spring just now to discuss opportunities, successes, and challenges that the practices are facing as they work to implement these initiatives. And as of right now, we have 28 of 40 physician organizations in Michigan participating in the program, 310 primary care practices, 21 endocrinology practices, and 15 nephrology practices that are participating in MCT2D. And what you signed up for the first year of the program, and what you're earning your value-based reimbursement on. And just to back up a little bit, there's a 5% value-based reimbursement for participants.
This I had to click there to participate in the meeting.
Sorry about that. These are the requirements that you're being held to earn your value-based reimbursement for this first year. We asked you to identify a clinical champion and a practice liaison for your site. We're having this current training session that you're part of now, which will meet this requirement. We have our practice change readiness assessment that we asked you to fill out just to understand where you are now with these interventions that we plan on deploying. So how your practice approaches prescribing the medications, CGMs, how you address these types of things. Attending the spring 2023 regional meetings. Later in the year, that's yet to be scheduled, we'll be hosting an endocrinology clinical champion meeting where we have not only you, the new sites, but the sites that started last year as well, and bring together all the endocrinology clinical champions in the program. And then we'll also be asking you to complete reflective learning on one patient case, have each physician in your practice do that by November. We'll share a template for that with you shortly. And this would just be a patient that you prescribed a CGM or SGLT2 or a GLP-1/2, and like some questions related to that and how you work with PCP practices on managing these patients. And the others are just responding to requests from us in a reasonable time frame. And then if asked, presenting at like a collaborative meeting, a regional meeting, or a conference call to share what you've learned with other sites. And the value-based reimbursement that you're earning for the program, it's 5% on all of your Blue Cross Blue Shield PPO patients, whether or not they have type 2 diabetes or not. So it is all of them for like your evaluation and management codes. And you receive this proactively. So you began earning this value-based reimbursement on March 1st, and it will go all the way until next February. And in the meantime, you're completing these requirements. So the simplest way to put this, I suppose, is for how the VBR works is if you previously would have gotten $100, for example, for billing a code, and you're earning that 5% reimbursement on Blue Cross PPO patients, you'd earn $105. So That's a kind of simple way to explain how the VBR works, and these are the types of things we're asking you to complete for that. As we mature the collaborative, these will change year over year and will move away from this participation-based to more performance-based VBR metrics, like I mentioned. So before I hand it over to Dr. Mizukami Stout to go over the training information that we have for you today on CGMs and the updated guidelines, does anyone have any questions about the TQI program, what we're asking you to do for your initial year of participation, anything else that you are uncertain about? You can also always reach out to me with any questions you have at any time too, and I'll go ahead and put my email in the chat so that you all have it easily available. And Dr. Mizukami Stout, I will hand it over to you.
Do you see that, my screen?
Yep, looks perfect.
I'm gonna move this really quick. Okay. All right, thanks so much for that introduction and some more details on MCT2D. So my name is Kara Mizukami Stout. I am an assistant professor in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan. I also practice at the Ann Arbor VA. And today we're just going to discuss a mishmash of topics, including updates and diabetes guidelines, specifically looking at the ACE consensus update that came out last month, CGM device updates, and CGM coverage updates. So I wanted to just briefly disclose that I am funded by NIDDK specifically to look at CGM use in type 2 diabetes. None of that is particularly relevant in this talk. So our objectives today are to review the updated American Association of Clinical Endocrinology, or ACE consensus statement for comprehensive type 2 diabetes management very briefly. Review the newest CGM technology and review updates in CGM coverage specific to Michigan. So starting off, so the ACE consensus statement came out last month or early this month, and consistent with the 2022 update, there's an emphasis on lifestyle changes in treatment of overweight and obesity, an emphasis on treatment of atherosclerotic risk factors, including hypertension and dyslipidemia, and they added a complication-centric approach for pharmacologic decision-making. And they have these really nice algorithms that I have a slide for each algorithm. We're not going to go into them in extensive details, just get a general overview of each algorithm. So as mentioned, lifestyle modifications and weight loss and maintenance are the cornerstones of type 2 diabetes therapies in the new ACE guidelines. Additional medication considerations should include not only glycemic targets, but complications, including ASCVD, congestive heart failure, CKD, obesity, and non-alcoholic fatty liver disease. And they also advocate for personalizing glycemic targets, though overall still recommending an A1C of less than or equal to 6.5% for most patients. So this is the adiposity-based chronic disease model, or the ABCD model, that you're likely familiar with, given that ACE has recognized this importance since 2017. So in this algorithm, the interventions for overweight and obesity are adjusted based on, number one, the BMI, and then number two, the presence of complications of overweight and obesity. And these include diabetes, cardiovascular risk factors, sleep apnea, osteoarthritis, GERD, urinary incontinence, PCOS, hypogonadism, and reduced fertility. And note that even normal weight patients are considered at least stage 1, and interventions for weight loss specifically should begin with any BMI of greater than 25. And then recommendations for weight loss medications are for any BMI greater than 27 in the presence of at least one diabetes complication, and for all patients with a BMI of greater than 30. And then bariatric surgery should be considered for patients with a BMI of 30 plus uncontrolled diabetes, or a BMI of greater than 35 with one complication. I'm not sure how much you all are seeing prediabetes patients in your clinic population. In our system, this is mostly managed by primary care. I did want to point out that the algorithm includes not only prediabetes based on a fasting glucose or an A1C, but also the diagnosis of metabolic syndrome as a prediabetes equivalent in terms of progression to risk for progression to diabetes. And so notably, the recommendations for medication management also differ based on the presence of overweight and obesity versus normal body weight with dysglycemia. And so in the first case, where you're targeting overweight and obesity, your goal should be a 7 to 10% body weight loss, while in the case of dysglycemia with normal body weight, you're treating specifically the dysglycemia. So for the dyslipidemia algorithm, so ACE, in recognizing that the importance of disruption in lipoprotein metabolism, specifically in type 2 diabetes, leads to an increased risk for atherosclerosis. All of the diabetes guidelines have really shifted to incorporating back to more of a treat to target type cholesterol reduction approach. Additionally, there's also more evidence now for the role of dyslipidemia in microvascular complications as well. So all patients with type 2 diabetes should have a lipid panel done at first visit or at diagnosis, and then a 10-year risk calculated, which is then used to stratify patients to determine lipid targets. And so this is done in conjunction with diabetes duration and age. And automatically, all patients with type 2 diabetes are classified as high risk with recommendations to add on a moderate intensity statin and targeting an LDL to less than 100. For higher risk patients in the 10 to 20% ASCVD risk range, that's when you move to a high intensity statin and target an LDL of less than 70. And in the extremely high risk range, targeting an LDL of less than 50. And in these guidelines, ancillary ApoB measurements are also targets as they better determine residual risk from remnant and small density lipoproteins. After initiating therapy, the recommendation is to recheck lipids in 6 to 12 weeks and then space out to annual once the targets are achieved. Also, on the right lower hand section of the slide, you can see there's specific targets as well for triglycerides in type 2 diabetes, aiming for less than 135 in those patients with diabetes and CVD, or at least 2 CVD risk factors. So in terms of the hypertension algorithm, hypertension targets are typically less than 130 or 80 for most patients. In patients with early complications or ASCVD, you can also target less than 120 over 70. And ACE inhibitors or ARBs are considered the first-line therapies with the subsequent algorithm delineated here. So shifting gears to diabetes-specific medications in type 2, the new ACE guidelines continue the focus of targeted therapy based on complications independent of glycemic control or other type 2 diabetes therapies. So in this algorithm, there's an emphasis on GLP-1 receptor agonists and SGLT2 inhibitors for those patients with ASCVD, heart failure, and CKD. In patients with stroke, a GLP-1 receptor agonist or pioglitazone can also be considered. The glycemic targets are an A1C of less than or equal to 6.5% for most healthy patients, or 7 to 8% for patients with a history of severe hypoglycemia unawareness, advanced CKD, extensive comorbidities, or those with a limited life expectancy. Again, they do recognize the importance of personalizing those targets. So if patients are not meeting their glycemic goals with the complication-targeted therapy, or the patient doesn't have any complications, then the glucose-centric model is followed similar to prior guidelines, incorporating essentially every other type 2 diabetes medication. And I won't belabor this slide. I'm sure you are all very comfortable and familiar with insulin initiation and titration for patients who need additional therapy for hyperglycemia. But I thought this was a really nice algorithm specifically for learners or for any trainees that you might have. Again, a very busy slide, but this is a nice summary slide of the risks and benefits of all of the diabetes agents to keep in clinic, to facilitate conversations with patients for shared decision-making, or, as a tool, again, for learners and trainees. And then another nice summary for obesity-specific medications. And then the last algorithm that ACE has is the immunizations for patients with type 2 diabetes. So now we're going to shift gears a little bit more to focus on continuous glucose monitoring devices, or CGM. I am sure that everyone here has been using CGM for quite some time because of type 1 diabetes. And so this CGM evidence is specifically for those patients with type 2 diabetes, and this is the summary of the evidence thus far, and randomized controlled trial and observational studies. So RCT data demonstrates a modest improvement in glycemic control and improves hypoglycemia and treatment satisfaction. And this is specifically in insulin requiring type 2 diabetes, including those just on basal insulin. As a result, all diabetes guidelines, including the ACE guidelines that we just talked about, as well as the ADA standards of care, support the use of CGM in insulin requiring type 2 diabetes. More recently, there's some smaller studies demonstrating some benefits in non-insulin users combined with other interventions, lifestyle interventions, dietary, exercise, etc. That data is pretty limited at this time, and because of this, most guidelines are not routinely recommending for non-insulin users. And these differences are reflected in the coverage for CGM devices, which I'll present later. Okay. So here's a quick summary of the guidelines as they pertain to CGM use in type 2 diabetes. So ADA recommends CGM in all patients with insulin, including basal insulin users. Endo Society focuses more on hypoglycemia reduction using CGM. And the most recent ACE consensus statement that we just discussed actually includes CGM for essentially all patients with type 2 diabetes for dietary modifications, exercise, and medication modifications. So I'm certain as an endocrinologist, you're familiar with all the CGM devices, especially in type 1 diabetes. I wanted to briefly go over the features of the newest CGM devices on the market. Starting off with Libre 3, this was approved in May of 2022. In contrast to the Libre 2, it's a real-time CGM. It does not require any scanning, and the sensor itself is about 70% smaller than the Libre 2. It's an all-in-one device with an expanded 33-foot range, and it has an 8.9% MARD. So other than that, the features and the connectivity are relatively similar to Libre 2. One notable difference is that it's not yet covered by Medicare because it didn't initially come with a reader. The reader device was approved in March 2023, so I anticipate that Medicare coverage will follow. We've also heard of reports of patients who are willing to buy the reader device out of pocket. Medicare will then cover the sensors themselves. So the newest CGM to the market is the Dexcom G7 device. As with all prior Dexcom G7 CGMs, it's a real-time device. It has a MARD of 8.2%. And the major upgrade is that similar to the Libre device, it's an all-in-one device, meaning that unlike the Libre or unlike the Dexcom G6, there's no separate transmitter. Also different is the back of the arm placement and the smaller size. It also comes with its own overlay patch. It has a nice feature with a 30-minute warm-up, which is reduced from a prior 2-hour warm-up. And then at the end of the 10-day sensor life, it has a 12-hour grace period. So this mostly impacts our patients with type 1 diabetes. It unfortunately does not yet integrate with automated insulin delivery systems. Surely this will happen, including some interoperability with other brand insulin pumps, and this will happen in the very near future, but not quite yet. And there's no coverage issues here for Medicare, which is really nice. It's still more expensive than the Libre. So our patients with Medicare who have the 20% copay, that's still something to consider, that it is more expensive than Libre still. So I'm certain that you all have encountered this in clinical practice. Up to 50% of patients experience challenges with skin adhesion and skin irritation with wearable diabetes devices, including CGM. And so I personally make it a practice to advise frequent site rotation and use of adhesive removal wipes as a first step. Other troubleshooting for adhesion challenges include prepping of the skin prior to sensor placement, or use of overlay dressings or protective sleeves. Some of these are available online, on Amazon and Etsy, etc. And then in terms of skin irritation, I've had some modest success with topical antihistamine sprays or nasal steroid solutions sprayed topically on the skin prior to sensor placement. These are typically kind of a temporary improvement. The last ditch effort is really to kind of switch this type of CGM device, as each CGM has their own type of glue. So finally, let's go over a few updates in CGM coverage, including the Medicaid coverage guidelines just released earlier this month. So insurance barriers and high out-of-pocket costs continue to skyrocket for both type 1 and type 2 diabetes. And I'm sure all of you are very familiar with the prior authorization process for your patients. I wanted to give a quick plug for the MCT2D resource library, which is available on the MCT2D website. And it has a bunch of other helpful tools, but amongst these is a really nice coverage guide for medications and CGM devices. It also has the most recent requirements, not only for private payers, but also for Medicare and Michigan Medicaid as well. So this slide is specifically the view of the CGM coverage guide. And in this tool, MCT2D has compiled not only what documentation is required, but also the preferred brand of CGM and whether or not CGM is covered as a pharmacy or a durable medical equipment benefit. And then, as you all likely know, the Medicare guidelines were recently revised. Medicare and most Medicare Advantage plans will now cover all insulin users. Patients not on insulin with a history of severe hypoglycemia or at least 2 episodes of level 2 hypoglycemia can also qualify. In either case, prior authorization is needed in patients with type 2 diabetes. Michigan Medicaid guidelines were also just updated earlier this month, effective as of June 1st, 2023. I think these guidelines were a really big win for patients with type 1 diabetes, as it no longer requires a prior authorization. However, it's a little bit unclear what the implications are going to be for type 2 diabetes. So Michigan Medicaid will reportedly cover all insulin users with type 2 diabetes or those patients with a history of severe hypoglycemia. However, a prior authorization is still needed for patients with type 2 diabetes. And that documentation for what's needed within the prior authorization is not really clear based on their statement released. But no prior authorization is needed for type 1 diabetes or pregnancy. So prescribing CGM, I'm sure all of you have prescribed these very frequently. Again, it's available as either a pharmacy or a durable medical equipment benefit. If you're sending it to a pharmacy, you send it in like a regular prescription, keeping in mind if you're sending it a G6 prescription, they also need the transmitter. And if their phone is not compatible, they would need a reader device as well. For a durable medical equipment benefit, it's a little bit more involved. The patient first has to contact their insurance company to see their preferred DME company. They have to contact the DME company, who will then fax a CGM order request to you for you or your office to fill out, along with a most recent chart note addressing a diagnosis of diabetes, number of injections, and a frequency of finger stick blood glucose checks. Now, Medicare has done away with the number of glucose checks. They do still require, again, insulin being documented. And if you have questions on whether or not a CGM might be appropriate for your patient, or whether or not what type of device needs a reader, or you can use a phone with them or not, there's a nice case guide on the MCT2D website that I've listed here below. So this is something that our collaborative members have mentioned as being a really helpful resource for e-prescribing for DME for CGM. We don't have access to Parachute Health here at Michigan Medicine or the VA. So I have not personally used this, but a lot of our members say that Parachute Health is a very simple tool to use, and it's got a good outcome. So it might be a tool to keep in your toolbox if you're not already using it. As with all EMR-based documentation, dot phrases are helpful to ensure that the elements needed for CGM coverage are in your documentation. And so here is one such example for CGM coverage, also similar for SGLT2 inhibitors, GLP-1 agonists, etc. So if this is just a quick plug for billing for CGM interpretation, if you're not billing for it, you should. It's added substantial revenue for our endocrine clinic here at the U of M. And so this is just a brief reminder of what that billing code is. It's a CPT code 95251, which you can bill if you report on a minimum of 72 hours worth of CGM data. You can only bill it every 30 days. And it has to be billed by either an MD or an advanced practice provider. Doesn't necessarily require a face-to-face visit. If you do have a face-to-face visit, you can use the 25 modifier, but you don't need it. So that means you can bill if a patient requests glucose review through the portal. Most insurances are covering this, at least in our experience. Some of the challenges that we've had with coverage are patients who get stuck with paying out of pocket if they have a high deductible plan. So with that, that's really it for in terms of like the learning. What we wanted to use this time forward to, number one, get a better sense of what questions you have and what feedback you might have in terms of future learning opportunities, and then ask some questions too about different types of resources that you all use that we might make some broad scoping recommendations to the rest of our collaborative members. So starting off first, does anyone have any questions?
I have a question regarding the use of CGM during pregnancy.
Mm-hmm.
So are both the Dexcom G7 and Libre 3 approved for use in pregnancy?
Yes.
And are the insurance going to cover for someone who is not on insulin?
That is my understanding. In both, that is my understanding is that they're supposed to. That's based on Medicare guidelines, though, right? Medicare and Medicaid guidelines, right?
Okay, so like we are talking about gestational diabetes here,
that's
right?
just it. Yeah.
Okay, because
So,
like
for private insurance, they may still have different coverage. They may still decline.
Okay, so like, are you using it for gestational diabetes? Because until now, only people who had diabetes before pregnancies whom I have continued on CGM, but I'm not really prescribing it for gestational diabetes.
So our clinics are using it. They are using it with CGM.
Okay. So how do you monitor for goals, especially on Libre? Because with Dexcom, you can change the target range, like 63 to 140, I think is the total time in range, or like the more than 70% time in range required. But in Libre, reports have not been able to change the targets. So how do you monitor those?
That's a great question. I'm not sure because I've only used Dexcom in pregnancy. I haven't used Libre in pregnancy.
So yeah, so that's a problem I run into when people already have Dexcom. Then it's great. I can just change it to 63 to 140 and it works perfect. It gives me a good, nice range. But Libre reports don't allow that.
Yeah, Libre reports are not allowing that. And I don't think that Libre 3 even allows that either.
No, it doesn't. No.
So I apologize. I don't have a great answer for that one because that is not something that I have used personally yet.
So Okay, so I guess I will then start looking into prescribing Dexcom in pregnancy and see how it goes.
Yeah, we've had, we haven't had any major issues.
Okay, thank you.
Any other questions?
Dr. Mizukami-san, there was a question in the chat. I don't know if you'll know the answer. If not, because it's billing related. If not, I'll find out. But do you know if you have to use the 25 modifier if billing 99214 with 95251?
Yes, if it's an in-person visit. We do, right? So we have actually an order set that automatically adds the 25 modifier for billing the 95251 code. So all of ours are automatically added to the 25 modifier if it's billed during a visit, yes. If you're not billing during a visit, then you don't have to add the 25 modifier, is my understanding. Any other questions? All right, well, I'll turn around and I'm going to ask some questions of you guys, and feel free to just speak out. First question is, how are the guidelines for diabetes influencing your approach to patients with type 2 diabetes? And if you do refer to them, which ones are you referring to?
I guess since no one's answering, I'll take a shot at it. So regarding the guidelines influencing the approach, I feel a lot of times it's the other way around, that as new things come out during the year, we start incorporating that into our management. And a lot of times the guidelines essentially, eventually next year, they will verify that what we are doing is fine. So like when Manjaro came out, we started using it, though none of the guidelines had any mention of it. And then, yes, finally the guidelines did come out mentioning that, yes, it's useful and it helps with fatty liver and whatnot. And then typically if I have to refer to guidelines, I do go with ACE guidelines.
Yeah, I think, as we get new data, it's important to recognize that that's not necessarily always incorporated in the guidelines. 100%, I agree with that. I think there's technically like differences with the level of evidence that's needed for guidelines versus like expert opinion versus consensus statements. So I think that probably factors into it. Like none of the guidelines are saying that we recommend this based off of, just one trial typically.
Mm-hmm. So it's like the example which I always laugh at is that when the guidelines came out, the most recent guidelines for the heart failure with preserved ejection fraction came out, they mentioned that there was no drug known which is known to decrease mortality in patients with heart failure with preserved ejection fraction. And during the same conference, within a few hours on the same day, Jardians presented their data showing that there is improvement in mortality. So those guidelines were current only for like a few hours, and they were outdated by the end of it.
That's true. That is definitely true. Speaking of that, are you all finding in your systems or in the patients that you're seeing a lot more of like nephrology and cardiology starting on SGLT2 inhibitors or GLP-1 agonists, or are they kind of deferring to endocrinology?
I feel they're deferring to endocrinology more often than not.
We've had a couple of instances. So for instance, at the VA, Jardians is a formulary medication. So it's really, really nice. It's very easy to get coverage. But we've had instances where we've had patients with type 1 get started on Jardians and then their insulin discontinued. And unfortunately, like that's not a good mix. So we're trying to kind of wrestle with what's the best way to deal with that when allowing other specialties to prescribe. Let's see here. Another question is, so in your offices, Are you using professional CGM or just personal CGM? First of all, and then if you're using professional CGM, what does that process look like? Like what staff members are doing that? And then same thing with personal CGM, really, who's doing the training? Do you have diabetes educators? Do you have nurses? Do you have, what staff members do you have available to you?
I guess so. We have both personal as well as professional CGMs available. So if you're putting on a professional CGM, that will typically be one of the MAs who put it on. In terms of the training for personal CGMs that we send to our diabetes educators.
Okay. What is that time frame typically looking like for you guys? Are they able to get patients in pretty quickly?
Yeah, so it's like as a professional CGM, more often than not, it's like patient will be there for a visit, and then once I'm done with the visit, I'll tell one of the MS to put on a professional CGM on the patient before they leave. In terms of the personal CGM, they call our office, and I think within the next week or so, they are able to get an appointment.
With the professional CGM, are you then having them come back to do a second visit for the interpret?
So yeah, so sometimes if it was put in at an appointment, then yes, they will often come back to go over the results. Sometimes what we'll do is that I'll have the patients come in like a week or 10 days before their next appointment to just have the CGM put on. So they'll come into the clinic, just one of the MS will put on the CGM. And when they come in for their actual visit, I'll be able to go over the results.
Mm-hmm. Okay.
But a lot of people, they forget that appointment and then they show up without the CGM on. So that doesn't always work, but that is sometimes that we do.
Yeah. That's true. That's one of the downsides is sometimes they don't come back. Is anyone using CGM inpatient?
Means we tried when COVID started up, but then none of the insurances wanted to pay for it. So that didn't really get anywhere.
Okay.
We got like the starter kit from Dexcom. And then once that was done, we didn't really get any more.
Do your the hospital systems that you work at, do they allow patients to use their own CGM devices in place of finger stick?
They do. They do.
Yeah. That's nice. That's nice. I think they're still requiring us to confirm with finger stick here. Okay, so we talked a little bit about the resources as well for CGM training. What I wanted to highlight next were some of the tools that we have, the resource library with the coverage guides and this for diabetes meds and CGM.
Okay.
Oh, sorry. That's the one. And then just a few other resources that I mentioned earlier in the talk. And that's about all I have, unless you guys have any other questions.
Okay, well, thank you all so much for joining, and thank you very, very much, Dr. Mizukami-san, for that really helpful overview and for answering the questions that came up. We'll follow up with everyone with the slides and with some of the resources that we discussed, and we'll let you know about the next requirements for the collaborative. Hope you have a great night.